Hi, I'm Dr. Thakore. Today I'm going to be talking about hypertension. Hypertension is a very common disorder. As a matter of fact, about one third of the population has high blood pressure. And a lot of people don't know when we talk about blood pressure, what exactly it is. And what it basically is a measurement of the cardiac output, how much the heart pumps out versus how much the resistance is in the blood vessels. So the two are combined. So if one of them or both of them are affected, the blood pressure will get affected. So I'm going to briefly just kind of talk about several points about the blood pressure and hypertension. First, I'm going to go over what the definition is. Next, I'm going to talk about how do we go about diagnosing it, and then who are some of the patients who have the risk factor for blood pressure, and then we'll talk about if it goes untreated, what happens to you if it goes untreated for a long period of time. And finally, I'm going to kind of just briefly touch on treatment options. I'm not actually going to go into all the medications that we use for hypertension. That's another talk all in itself, but I'm briefly going to kind of touch on some of the initial things that we can do to bring our blood pressure down. Okay, so first of all, I'll talk about how do we go about what is actually the actual diagnosis. So over the years, they have come up with different numbers to actually diagnose, and the current consensus is any blood pressure that is above 130. So normal blood pressure is considered blood pressure of 120 over 80. So now they're diagnosing it as any blood pressure that we have above 130 is considered hypertension. Even within that, there's 4 stages. As the numbers go up from stage 1 to the highest, which is stage 4. So we label them based on how high the blood pressure is. Now, this is how do we go about diagnosing it? And this is one of the things I've noticed that our healthcare system is kind of falling behind in as far as the diagnosis itself. Most of the patients that are getting diagnosed with hypertension, they're office-based. So there's actually 3 ways you can come up with the actual diagnosis. You can do an office-based, or you can do a home-based, and then, or we could do what's considered actually the gold standard, which is ambulatory blood pressure monitoring. So let's talk about the office-based. Of the 3, I firmly believe that it's most likely the least accurate of the 3. So we do is we have, as we come in a doctor's office, the doctor or the nurse measures blood pressure, so walk in. That's really not the way you want to do it. You want to have the patient come in, you want to have the patient resting for about 5 minutes, and what you want to do is you actually it'd be better if there's a blood pressure machine and there's no one present in the room, because if somebody is present, the likelihood that your blood pressure is probably going to go up a little bit. So the most accurate way is have somebody come in, wait for 5 minutes, have nobody in the room, have the machine on, and do 2 measurements. And what we're supposed to do is we're supposed to average the 2 measurements. And this is not something that's commonly done in most doctors' offices. Now, what is the other way of diagnosing it? You can also do a home-based, where a patient gets a really good blood pressure monitor and measures it at home. And you have to get about 14 readings over a period of 1 week. So you get a morning and an evening for about a week, and then we average the numbers out and see what comes up. Now, I think it's a little bit better than the office-based, because the office-based, again, it does not pick up what we call the white coat hypertension. So white coat hypertension is when your blood pressure is high in the office, but when you're at home, it's fine. And there's a lot of factors involved. There are some patients that have white coat Every time they walk in, they're very anxious about the blood pressure. The blood pressure is high, but the rest of the time, it's normal, it's fine. And so if you just do an office-based one, you may miss a hypertensive patient. On the other end of the spectrum, you can also have a patient that is actually low in the office, but is high the rest of the time. So we call that masked hypertension as well. So both of those, again, if you just do office-based, it does not pick those patients up. Now, the one I actually like of the three, and is actually considered the gold standard, is the ambulatory blood pressure monitoring system, where there's a device that a patient wears, goes home with, and it measures the blood pressure every 30 minutes to 60 minutes for about 24 hours up to 48 hours. Now, there's a machine that records everything, and at the end of the day, when you turn it in, there's a computer that calculates, that averages all the figures. Now, the good thing about this, not only does it measure your blood pressure during the daytime, but it also measures your blood pressure at night time. Because we're noticing a lot subset of patients that have blood pressure elevated significantly during the nighttime. Typically, our blood pressure is supposed to go down about 15% at nighttime. And there's a subset of patients that doesn't actually happen, and those patients are definitely hypertensive. So again, so there's office-based, home-based, and then ambulatory monitoring. So those are the three ways that we're using to diagnose somebody with hypertension. Now, next I want to talk about what are some of the risk factors. So what are some of the things, who are the patients that are actually getting hypertension? So there's a class we're calling modifiable and non-modifiable. So non-modifiable is something like age. As we age, the blood pressure typically goes up. It just has to do with compliance of the arteries. The arteries just get stiff and non-compliant, and over age, the blood pressure tends to just rise. So that's a non-modifiable. Another one is if you have a family history of blood pressure, there's a strong chance that you may develop it as well. And then, what are some of the modifiable risk factors? Now, these are the ones I want to focus on more, because these are the things that we can actually do to get somebody's blood pressure down. Those are obesity, if you're taking a high salt intake, alcohol, and inactivity. So those four are the big keys here that are considered the non-modifiable. And I'll talk about them more in detail when we talk about lifestyle modification. Okay. Now, the other thing I want to talk about is what is primary, or we call essential hypertension, versus secondary. So primary is what 90% of the patients have. We don't really understand the full pathophysiology why certain patients actually just have primary hypertension, but 90% of patients have it. But there's a 10% subset that actually have secondary hypertension. And those include, the number one thing that includes is medication induced. So even things that are over the counter, like Motrin, naproxen, a class of drugs called NSAIDs. Motrin, naproxen, Aleve, ibuprofen, those are a class of medications that are used a lot for arthritis and different reasons, but they do tend to increase the blood pressure. That's one of the medications. Another one that I see a lot over the counter is decongestants. Things like Sudafed, used for common colds. So those are some of the medications you can use over the counter. Now there are even some prescription medications that will rise the blood pressure, and one of the ones that we see is oral contraceptives, and even some SSRIs as well. Now, some of the other secondary causes that I see very often is obstructive sleep apnea. If I see a patient that we put on 2 medications, 3 medications, 4 medications, we can't get their blood pressure down, I've noticed that they are the ones that usually end up having a secondary cause, such as obstructive sleep apnea, that has not been diagnosed. And the good news there is if you treat the underlying sleep apnea, the blood pressure tends to go down. So there's some other subsets that also have kidney disease, such as renal artery stenosis, that can get secondary blood hypertension as well. And if you have a young patient, let's say in their first and second decade, their blood pressure is high, they tend to have a condition called coarctation of the aorta, which can lead to hypertension. So that needs to be worked out. Okay, now let's say we've gone over how to diagnose it, what are the risk factors, what are the primary and secondary causes. Now, why is it important? I mean, why do we care so much about blood pressure? Because hypertension is known as the silent killer, because until it causes end organ damage, most of the patients have absolutely no symptoms. So it's a silent. That's why we have to be so vigilant about somebody who has high blood pressure to make sure that it's under control. Now, what are some of the end organ damages that can happen with hypertension? I like to think about it as it can affect the eyes. In the eyes, it can cause a condition called papilledema, where the optic nerve gets swollen, and that can lead to vision loss. So that is a big problem that can happen. Next one is the brain. Long-standing hypertension increases risk for stroke, both hemorrhagic. Hemorrhagic is bleeding strokes, or strokes from thrombus. Now, the other organ it also affects, the brain, eyes. Next is the heart. Heart, it can cause, so if the blood pressure is consistently elevated, the heart has to work extra hard, has to work harder, and the heart muscle actually gets hypertrophy. We call left ventricular hypertrophy. That increases the risk to become congestive heart failure. So within congestive heart failure, there's two types. The most common cause of diastolic congestive heart failure is related to hypertension over long periods of time. And the next organ that it actually affects is the kidneys. So you can go ahead and kidney disease of a long-standing hypertension. It can damage the kidneys in a way that you can even end up being on hemodialysis. It's one of the most common causes of patients needing hemodialysis because of uncontrolled hypertension. All right, so we've gone over what happens if you have it. So what are some of the things that we can do about this? Again, I'm not going to go into detail about all the cases that are used, but I'm going to talk to you. Somebody is first diagnosed with blood pressure. One of the first things that we usually recommend is lifestyle modification. Okay, so this goes back to the modifiable risk factors. Again, inactivity, increased physical activity, 30 minutes a day, 3 times a week, moderate intensity is what I recommend. Weight loss. If you are overweight, and every kilogram of weight that you lose, you drop your blood pressure by 2 to 3 points, and that is known. Decrease of salt intake. Salt intake is huge in our population. It's what I like to call standard American diet. A lot of salt in it. And I'm not even talking about the salt that's added on top of it. Talk about all the processed foods actually have salt in them. Now, another thing that you can do is increase foods that have potassium containing foods. Bananas. There's a whole list of, you could probably just Google them, what the potassium containing, but increasing just the potassium containing foods can actually lower your blood pressure over time. And then getting into more detail about the diet, they have found that there's a diet called the DASH, DASH diet, that has proven in studies to lower people's blood pressure just following. It's primarily based on eating high amounts of fruits, vegetables, low-fat dairy, and good so increase the amount of fat for the heart, and as well as decreasing the amount of salt, decrease the amount of sugar in the diet. So that's basically in a nutshell what a DASH diet is. And lastly, I'm going to kind of touch upon what if somebody is interested, if there's a supplement that can help. There's not a lot of research on this currently. However, we've noticed that magnesium-containing supplements do tend to help with the blood pressure, and as well as omega-3 fatty acid supplements. So again, I'm not going to go into detail about all the different what are some of the medications that we use, but I see patients that are on 3, 4, 5, 6 blood pressure medications, and again, some of these modifiable risk factors were not applied in those cases, and if they were, I would suspect that most of these patients we could get down on their blood pressure. Thank you very much for your attention, and if you have any questions or comments, feel free to leave a message below. Thank you.